to answer the questions so that we can have comments for all the items we'll discuss, is how do we manage mechanical ventilation ARDS? I just mentioned 11 magic rules. So no conflict of interest. This is the case, it's a 58, but can be whatever age you want. An emergency department, consciousness, severe dyspnea at rest, activation of respiratory muscles, and what's more important, respiratory rate is 35, and oxygen saturation in air is 85%. This is the patients coming in the emergency department. So this is the first question we have to answer. So what do we do? Venturi mask with FiO2 100% or 50%, or we start immediately NCPAP or NPPV. Those of you who have the device, please answer and vote. This should start. They told me. What happens? They told me to click on start vote. I don't know how long it takes.
16, 15, 14,
do you have
13,
because I have no...
12. I have a magic screen here. 9 seconds, 8, 7, 6, 5, 4, red, become red, great, 1, done.
So it's a very mixed answer. So you see around, or Venturi mask 100%, 50%, or CPAP, okay? So I propose, but this is, of course, is matter of discussion. And for example, what do you think, Luciano? Well,
I would, for 5 minutes, give 100% oxygen and see where the saturation goes.
That's what I also mentioned here. We did not agree before.
Not forever.
But I don't know. It's well, this is, you see, there's a difference between everyone. Why that? Because the first rule is to identify patients for non-invasive or invasive respiratory support. And you know this is from NUN, applied physiology. This is the arterial PO2 and shunt, and the response to FiO2. And as you can see here, if you use high FiO2, you can have a major difference, differentiate patients with higher and lower shunt. And if you use a lower level, like 50% of oxygen, the problem is that you mix also the possible effects of VQ mismatch, which is not really what we are looking for in our patients. So we are just looking for the true shunt in a simple way in the emergency department. So this is coming from a Gattinoni paper, and this in red is a little bit a revision of that, just to make a little bit discussion. So you have a patient like this, you can start with 100% oxygen, you assess the response. If it is less than 96, 95%, you are sure that this patient is very severe, okay? Because you are sure that PO2 is lower than 100, 120. If it's between 96, 98, you cannot differentiate if it is mild or moderate ARDS, because you don't know the PO2, so it's absolutely mandatory to perform a gas exchange analysis. So we perform the FiO2 test, and the PO2 does not increase too much, it's 85 with Venturi at 100%, and this is the chest X-ray. So it's clear that the patient is a quite severe ARDS in this condition. So what we do now, high flow oxygen, or NCPAP or NPPV, or we intubate the patients immediately. Please vote. What do you think?
20 seconds. Well, with a patient...
Is 85 at 190% oxygen right now? Do you intubate or you try to do something?
From 85 to 100 to 100 saturation means the shunt is lower than 33%. I would wait some, I'm not in emergency. I would wait just to collect some notion what the patient has, pneumonia, some news. So I don't have to take the tube and run. I would keep some time, and I would use CPAP at this patient.
So now we look at the response. So more or less, the majority would use NCPAP, or others, they would intubate the patients, which is the main question, okay? Gattinoni is suggesting CPAP, and my answer could have been endotracheal intubation because the patient is very severe. But of course also NCPAP could be a very good choice in this section.
Just a second. The problem is what very severe means.
Yeah.
To me, very severe in the Berlin classification is nothing else than SBAUG classification. That means refractory hypoxemia. Refractory hypoxemia is the impossibility to reach normal PO2 and normal saturation with 100% oxygen. If I have 100% saturation, I not have a severe ARDS. Maybe I'm moderate, severe, I'm in the range.
But the PO2 was 85, 90, yeah?
But
so
85% with saturation, with the saturation 100%, something wrong.
No, 85
millimeters of mercury
with 100. So
with 100.
But anyway,
it's okay.
This is the real life.
I think it's openable, but
it's open. Yes.
Nobody goes in jail, baby. Okay, go ahead.
And you know, this is a recent trial suggesting the high flow oxygen, that it was not mentioned in the answers, but was not chosen by you. And also I see by Gattinoni, and you see from this study, they suggested high flow oxygen in these patients, even with PO2 FO2 lower than 200. But this is just a first study. We need more confirmation about this. And so what the physicians did was really what was suggested. So they started, in this case, not CPAP, but NPPV, with pressure support, 10 centimeters of water of PEEP, a quite high level of pressure support at 25, relatively high FiO2, and the PO2 FiO2 after 1 hour, 2 hours, was 125, so with 100 of oxygen, and the pH 727, BSXS -5. So also hemodynamics is not just perfect. You see blood pressure starts to have some problems at 95. So there was a test in NPPV, so in non-invasive ventilation, exactly as you suggested, and it was discussed. So this was done, in this case, in the intensive care. And I think we have to remember, anyway, that the consequences of possible errors due to inappropriate early intubation are less severe. This is just open for discussion. Then possible errors are associated to the lack or delay of intubation if needed. This, I think, is something that can be discussed. This means that we can try, but we have not to wait too much. What do you think, Luciano?
Well, I think it's correct because I wrote it, I think. No, because if you do a wrong intubation and you realize that's wrong, it's quite easy to correct the problem. You take out the tube. But if you wait and the patient is more and more engaged in respiratory failure, and you decide to intubate a little bit late, as soon as the patient sees some or curar or some sedation more, remember, you lose the tone, the FRC will decrease again, we have a further collapse, and the risk of bradycardia and possible really important hemodynamic consequences are very high. So I wouldn't wait until the exhaustion of the patient. I prefer to anticipate. This is what means that sentence, nothing else. Yeah.
Okay, then we move on, and now we intubate the patients, and the rule 2 is avoid inspiratory stress. So low inspiratory plateau pressure of the respiratory system, and to try to ventilate patients protectively, avoiding, at least at the beginning, a plateau pressure higher than 25, 28, 30 maximum centimeters of water. We have several studies showing, like this is one from our meta-analysis some time ago, clearly showing that if you collect all the data published, the low tidal volume and low plateau pressure appears to be really beneficial on outcome. So the rule 3 is we intubated patients, we added low tidal volume, we look now at the plateau pressure to identify recruiters and no recruiters. So now the question is, do we need recruitment maneuver? We don't need, we need higher PEEP, we don't need higher PEEP. This is a study from Gattinoni showing that you can see here from the right, some patients who are not recruitable, you please increase the level of pressure, and you see there are no major changes in the densities, while on the left side, you see a major changes in the density when you apply different pressure. It's very likely that this kind of patients can benefit from higher level of PEEP and recruitment, while the other patients do not require higher level of pressure and PEEP. But of course, this can be clearly identified at the CT scan, but it's not always easy to bring the patient to the CT scan. So we have to do something at the bedside. So now you have the patients intubated. Which is the starting PEEP you would apply in this patient with protected tidal volume? This is not a PEEP test. This is just when you start. What do you think? Start voting. Luciano, what do you think? What do you do?
It is not real clear at this moment how much is the real severity that require a more...
No, you are just
okay, but you are just in a waiting time, yeah. So not too much and not too low. I would put 10.
10. Now we see...
If it would be Summers, we would use 12, but in our system we use 10 because it sounds better.
So the answer, where is the answer? Can we have the answer, please? But anyway.
Star vote, you did?
It does not appear. Okay, anyway. More or less 5-10 centimeter water we can apply. Why that? This is a study from Gattinoni group showing that you see those patients at 5 or maximum 10 centimeter water, if they don't can be maintained at this low level of PEEP, you see that the potential of recruitment is higher in those patients who present the characteristic of severe ARDS, or we can say severe moderate ARDS, so less than 150 at a relatively low level of PEEP, so 5 to 10. So this is a good way to identify patients who are more likely to need recruitment and higher PEEP. And I also suggest, I know these are very old studies, that also pressure volume curve can be a role, not to identify the best PEEP, but mainly in general, a linear PV curve suggests not much recruitment in general, while inflection point is likely to suggest more likely to have more recruitment. So a combination of PO2, FO2 at relatively low PEEP, 5 to 10, and the combination of information from PV curve, I think can give us a quite good information at the bedside if you are likely to be recruited or not. So this is the situation right now. So control mechanical ventilation in pressure control, supine position, protected tidal volume, plateau pressure of the respiratory system 27, PEEP 10, as we say, FO2 80%, PO2 FO2 160. So according to this data, there is also an inflection point in the curve. The patient is quite recruitable. So we need to do more, very likely. So at this point, what do you need? We need some hemodynamic monitoring. I think you agree. And what do we choose? Invasive arterial pressure, just invasive arterial pressure before to start the real PEEP test. Now we are going later, so non-calibrated monitoring, calibrated monitoring, or Ashwagandha catheter. Please vote. We should start now. So what do you do, Luciano? You think that you have need some
well, at this point, having the data you had before, yeah. I would put hemodynamic monitoring, yeah. But I would increase PEEP.
Yes, yes. No, but this is we discuss after. Yes,
now
it's a question of which kind of hemodynamics.
Which kind of hemodynamics? Well, nobody likes now the Ashwagandha catheter, okay? And what is, well, 10% is still something like that. Well, of course, the arterial pressure, everybody gets an arterial pressure, that's it. We use the Ashwagandha catheter when we have doubts about, as a diagnostic tool more than as a monitoring tool. When we have doubts on the genesis of the edema, that means how much is due to the possible hydrostatic pressure component. Because the inflammatory versus hydrostatic edema is present in the book. In the reality, you have a great overlap of the two. So, but in this case, I would start with arterial pressure, but I would be a little bit worried about the PEEP. To me, is I suppose you will increase the PEEP now, because
So,
it's still.
It's interesting that most of you, they just use the invasive arterial pressure, so they will just have information from, I suppose, pulse pressure variation, if in terms of hemodynamic. And while very few you use calibrated or even the Schwann-Ganz catheter.
But what I put here, more than maybe it's already in, but I would put the central venous
This is there, of
pressure,
course.
because I think the best hemodynamic monitoring we have in this situation is to measure the SVO2. Because the SVO2 compared to the arterial CO2 give you an idea on how the body responds to the pressure you use.
As you can see here, this was in place, saturation 67, was in place before.
SVO perfect, great. This to me is more than...
So we tend to use the calibrated system. You use a calibrated system in this patient, but
Yes.
of course this was open for discussion. We use much less Schwann-Ganz, but at least my concept here is that we need some hemodynamic monitoring. So now we have to optimize mechanical ventilation. So this is just some discussion about hemodynamics, but we can move on. So, it's a recruitable patient. And should we perform or not recruitment maneuver in this condition? The patient has a relatively low PO2 FI2 ratio with 10 of PEEP. The question is now, before the PEEP test, how many of you don't perform any recruitment? How many of you use recruitment maneuver before PEEP test on CPAP? How many of you use a sort of slow recruitment maneuver? And how many of you would use just a recruitment maneuver, increasing PEEP and increasing the pressure control? So this is just a question how many of you would use recruitment maneuver or not, and which kind of recruitment maneuver in this condition before PEEP testing? Do you use recruitment maneuver before PEEP?
Well, in a case like this, but we have a little bit different. A patient like this will go to the CT scan, but without a CT scan,
without the CT scan,
we use 5 to 45 for a while. But remember that opening pressure in a patient like this, at least 45 are enough. But remember that afterwards you ventilate with 30.
Yeah.
There are some which open up between 30 and 45. If you don't change anything, if you start to ventilate at 30, they will be closed again. So but anyway, the recruitment maneuver is in that way.
And we see that most of you are performing anyway a recruitment maneuver. There is some variability in which type of recruitment. I think is supposed to be, because we don't know really which is the best recruitment maneuver. We perform more and more now the slow recruitment maneuver because we have animal data suggesting that this, at least in the short time, might be associated with less induction of inflammatory response during the maneuver. And so the rule 5 is we suggest to perform recruitment maneuver in this case before the PEEP setting, and slow is better. This is one proposal of recruitment maneuver. We don't do exactly like this, so it's a progressive increase in PEEP and inspiratory pressure up to 40 centimeters of water, eventually 50 or 60 at the maximum, with very cautious and monitoring hemodynamics, and maintaining driving pressure constant. We don't reach levels up to 35. We usually reach levels at 20, 25 for a very short period of time. But the importance to me is that we found that increasing pressure and peak during recruitment maneuver is better in terms of less induction of injury to the lung or activation and inflammation. And this is always before the PEEP setting.
May I have one question? How many of you do still use the stethoscope? And the balloon in the hands? Very few.
Very few.
Because if you combine the two, Sometimes you do perfect recruitment maneuver.
Or
You
the
can-
sonography. We will say, see, after, or the echography now
Yes,
in
yes.
place of the...
You can hear the echography just tell you what the ear should. Okay, but you still have hands and eyes. Okay, we have great.
This is, just to remind you, is a nice meta-analysis. Of course, it's not conclusive data, showing that recruit maneuver associated with PEEP as compared with no recruit maneuver, even there are many studies with a high risk of bias, seems to be associated with better survival. But, of course, this is a meta-analysis, is not a randomized controlled trial. So, now we have the question, we have to perform the recruit maneuver, we have to set the PEEP. And we have, I just mentioned it here, four possibilities, choice. Based on the PO2FO2 table by NIH, based on the best compliance after the recruitment, we are going down with PEEP, based on the stress index, or based on the absolute level of esophageal pressure at the end expiration. Please start vote. It's interesting to see what you know, what you would do. I suppose the...
Our rule is very
equilibrated.
equilibrated, 20, 20, 20. Very clear idea, great. Okay. 7, 6, 5.
Wow, so most of you would use an individual approach on compliance. Can you have a comment on that, Luciano?
Well, I spend, I think, most of my life trying to look at the compliance changes and so on. And I don't think it's the best method of PEEP, but we don't have any best method of PEEP, of course. When you say based on best compliance, what you really mean?
I mean that you are going down, I will show,
The best
you're going down
compliance
from
of PEEP.
higher PEEP to lower PEEP, and you look at the PEEP at which you have the best...
And you look the best compliance or the best oxygenation in that way?
This is best compliance in this case.
Well, when we compare different methods, I don't remember if we compare this one, we found that the table, PO2 and FiO2 table, were the only one which were able to discriminate between higher PEEP in more severe and lower PEEP in less severe. Because what is the real problem of PEEP? In severe ARDS, we know that to keep this lung open, you need a PEEP between 15 and 20. The problem is, I'm wrong in giving higher PEEP in patients with moderate or mild ARDS. I have to avoid a high PEEP in this problem. So we have to a little bit to tune. The PO2 table tell you are able to discriminate that. If you use the opening lung concept, greater is the PEEP, better is the situation, which is not exactly what you want for a continuous ventilation. Let me give an example. I have 30 seconds, an example. What would be an ideal system? When there is not recruitability, the best PEEP will be 0. Do you agree? When there is recruitability, the best PEEP is opening. Now, let's assume I take a perfect normal lung and I apply, let's see, the express method, which is I put 6 milliliters standard volume, perfect lung, but I think that this lung has an RDS. Somebody told me, this is very severe RDS. I set PEEP in a perfect lung. I use 6 milliliters per kilo, 5 of PEEP. I reach 10 plateau pressure, I increase. I increase 7 of PEEP. I reach 12 of plateau pressure, then 13, 14. When I arrive at 20 of PEEP, still my plateau pressure is not 30. So better is in the healthy lung, this system lead to select PEEP at 20. Because better is the lung, greater is the PEEP, as the same thing more or less with the stress index, which have other advantages. But for selecting PEEP, be careful. What we know, always think that the real problem is to avoid high PEEP in, I think, moderate and severe. In severe RDS, whatever system give you the right PEEP, give you 15, between 15 and 20. If you apply stress index, love, the tables, and so on, we found, Chiumello published a paper on that, we found between 15 and 20, even with a CT scan. The problem is the moderate and mild RDS. So at the end of the story, if you don't want being crazy, I think if you measure the severity of RDS, if the PEEP, is severe, I put 18 of PEEP and look at the hemodynamics.
This is the slide that you're referring. If you're in a hurry, you have a sort of severe, moderate, or mild RDS, and you can apply, in this case, 16 to 20. In this case, 11 to 15. You don't do any PEEP test, and in the other case, 5 to 10. So this is very simple if you want to be in a hurry. If you want to be more precise, as we discussed, now we have a different proposal. The PO2FR2 table, higher PEEP and lower PEEP, but this is also an issue. I think we have to separate higher PEEP in more severe, eventually lower PEEP in moderate. So I think this should be used both according to the severity. And this is the study from Suter. I think we have to be back to the old studies.
Still is one of the best systems to select the compliance.
So I think these two studies should be, so I think that one method or the other, and the best compliance here is not the express method. This is completely different. This is the compliance changing the PEEP. So that is represented here. You have a recruitment and you go back in volume control and you set the PEEP according to the best compliance, okay? This is the Suter method, which seems to be almost good as the PO2. This is the express. The express is completely different. You are using a fixed plateau pressure within the limits, and then you apply the highest PEEP, as mentioned before, to reach the target tidal volume. So in this way, you extremize the level of PEEP. And this is the study that was mentioned before by Gattinoni. This is just to show you the role of transpulmonary pressure at end expiration. You know this study from Talmor, below from our patient. And you see here the concept for esophageal pressure is that this is the transpulmonary pressure, so the difference between pressure at end expiration and the absolute level of esophageal pressure. You see the transpulmonary pressure here at end expiration is negative. So means that the PEEP, the level of PEEP, is lower as compared to the pressure in the thorax. Then you increase the PEEP, and you see that the transpulmonary pressure now is almost zero. And if you, according to this concept, you should use a PEEP level in order to reach higher positive transpulmonary pressure. So this is another concept which has to be further tested. And this is the study that Gattinoni was mentioning before. This is the amount of lung recruitability, higher recruitability, lower recruitability, using the PO2FR2 table, in this case at high PEEP level. I think then we can discuss higher or lower according to the severity. Probably this can even be improved more. And you see that those patients with higher recruitability were associated with higher level of PEEP, as best PEEP according to the PO2FR table, while patients with lower recruitability, even using the higher PEEP table, were associated with a lower PEEP level. With Express, which is not the best compliance again, and the stress index is completely the opposite. The PEEP was lower in those patients with higher amount of recruitment. And there was no difference by using the absolute level of esophageal pressure. This is one study. I think it's quite convincing. There are other two studies on that. This is a study which did not use the CT scan, so this is a major limitation as a standard method. And you see that oxygenation by PO2 table or stress index, they were associated with higher PEEP level and with higher amount of recruitment. But again, this study did not use the CT scan as a standard method. And this is the third study trying to compare different systems. In this case, they used the NIH table at low PEEP level and the best compliance according to Suter and Express, and they found that the best compliance was the best compromise. So anyway, overall concluding, I think that the PO2FR2 table table, and the compliance, like the Suter method, not the express method, might be considered.
May I have a short comment? Be careful in all the methods, and of course also the PEEP tables, when relate the recruitment to the oxygenation, because the oxygenation does not depend only from the recruitment, but from the hemodynamic safety distribution. It's extremely important.
This is the slide showing this.
Always to remember that. And the second, whatever system based on the compliance changes, assume that the changes in compliance are due to recruitment of new pulmonary units. And this is wrong, because it's not only this, but if you look at the normal VP curve, and the compliance you measure is a chord compliance, or a straight line, when you start with a higher volume, you have a better compliance, just because the surfactant system is already overcome. So it's not only that one. The best compliance give you an overall better inflation, which includes the recruitment plus the better inflation of units which have already opened. So at the end of the story, I think the conclusion that Paolo took are reasonable. And at the end, remember, the problem is not the severe RDS, it's the moderate and low RDS.
And the ecography, I think, there are several studies right now. I suggest to use more and more ecography also to get more.
I'm too old for that.
So we can skip this. And now that we have the patient, so we PEEP test, in this case with PO2 table, and the best PEEP was around 18. PO2 improved, 150. Plateau pressure is 35. Plateau pressure is 35. So we have to pay something right now. And so low tidal volume, PEEP 18, this is a severe RDS, so this is according to what we discussed, but plateau pressure of the respiratory system is 35. So now, what do? We reduce the tidal volume and the driving pressure, we reduce the PEEP, we reduce the tidal volume and the PEEP, or we measure the inspiratory pulmonary stress by using the esophageal balloon and the transpulmonary pressure. Please start voting. Luciano, what do you do now?
And of course, where we measure the real force applied to the lung with the transpulmonary pressure. So we measure the esophageal pressure. And in some patients, with obese patients, pregnant women, or patients with some alteration of the chest, you may have surprise. So is
and we will see now. So you see, most of the people would reduce the tidal volume. Interesting. So most of the people is defending the PEEP, and you reduce further the tidal volume. Very few are using the transpulmonary pressure, also because it's not always easy and available.
This would be my second choice, just reduce a little BSO. But
and in fact, our doctors, you see, did exactly this. I did not know that. And you see, they reduced the tidal volume at 4. They maintained the PEEP of 18, and plateau pressure now is 30. But you see here in red, you have some problems, because now the pH is going down, even if the respiratory rate was increased, as you see, at 27, and the PHCO2 increased at 74. So now we have to decide to do something, and the suggestion right now is try to go to the transpulmonary pressure in order to see if we can do something.
Paolo, just one verbal caution. Everybody is accustomed to have hypercapnia, but we have always to remember that hypercapnia means hypoventilation.
Yeah.
Hypoventilation means a great risk of reabsorption at atelectasis. Because we have hypoventilation means I have less gas into the pulmonary units than the gas which has been potentially extracted. That means the unit close. That means the pulmonary artery pressure goes up. That means the right heart getting crisis. So it's not completely innocent. The hypercapnia per se is innocent, but the sign of which is manifest may be very deleterious. So be careful when you have these values as a 70, which are very high.
So we put the esophageal balloon, and we can do two things. The first, you see the esophageal pressure here and the airway pressure, and you can measure the difference in esophageal pressure and airway pressure, so we can have the compliance of the chest wall and the ratio between compliance of the lung and the chest wall. And then the maneuver, this was suggested by Gattinoni group and discussed that how to measure the absolute transpulmonary pressure is relatively easy. You see here, you reach here 30 centimeters of water, exactly as our patient has, with higher PEEP level. You go down up to 0 centimeters of water very fast. And so you know the difference between the airway pressure at plateau, so 30 minus 0. And this is the esophageal pressure. We don't trust too much in the absolute level, so you have the absolute level and the inspiration at 30, in this case 12, and this is 6. And if you measure the difference between the difference in airway pressure between plateau and end expiration at 0 minus the difference in esophageal pressure at plateau and at end expiration, you can measure the real transpulmonary pressure. So in this case, it's not the patient. In this case, it's 24. I think it's quite clear enough. So from the changes that you get from the airway pressure and the esophageal pressure, not the absolute values, you can estimate the absolute transpulmonary pressure. And now this is a very interesting recent study that you can avoid this if you measure the airway at end inspiration multiplied the ratio between the elastance of the lung and the respiratory system that you measure by occluding during tidal breath. So that's what exactly we did, and you see that when we have 35 centimeters of water, so we have a better ventilation with protected tidal volume, the real transpulmonary pressure was 21. So it's within the maximum limit of stress. And even if you don't do that with changes in PEEP, but just looking at the airway pressure, multiply the ratio of the lung and respiratory system that you see in this case was 0.6, you can compute approximately the same level at 21. So with this method, you can have a good estimation of the absolute transpulmonary pressure that you reach, and you see we have a major information. We don't need to reduce further the tidal volume. We can keep the PEEP that we set, and we can keep 35 of airway pressure, because this airway pressure is really equivalent to the maximum level of stress acceptable in these patients. So this shows you how it can be important to set mechanical ventilation appropriately in very difficult cases.
Okay, let me just a few words about the 21. From where this number comes? Because when you are at 23, 24, you enter in the region of total lung capacity. That means whatever is the dimension of the lung is at its anatomical limits. And we know that we ventilate animals at these levels of limits, the ventilation is lethal in 24 hours. So 21 is already
at the maximum.
Three red lamps.
Yeah. In fact, we will see that we have to do something more. So this is just a fast question, because this is just to remind you the role of sedation and paralysis. As you can see here, you can start voting. Are you going to just use deep sedation in this patient, or sedation and neuromuscular blockade with continuous pump, or sedation and neuromuscular blockade by bolus? Please answer. It's just a collateral question here. Then we have just 10 minutes, and we will be perfectly in time. So most of you answered that they are using sedation and neuromuscular blockade in pump. Can you have a comment? Of course, this is coming from the Papazian study, but I think that Luciano can have a comment. Do you agree on that? We did that, but...
Well, I know there are several opinions. I personally prefer, during the full-blown state of ARDS, to keep the patient quiet, sedated. I don't hesitate to use paralysis to have all the mechanics, measurements, so on. So you characterize exactly the patient. And if I think to myself, in an intensive care with ARDS, awake, with this tremendous respiratory drive that this patient have, because spontaneous breathing in this patient is terrible at the beginning, they have a swings of transpulmonary pressure of 25, so that means a total lung capacity. I would agree. I would heavy sedation and sometimes a paralysis too.
That was exactly what was answered by most of you. So now it's a very clear concept. This is coming from the Papazian study, and it's clear that in more severe ARDS, at least in the first 48 hours, or when needed, deep sedation and paralysis.
Somebody is not agree, but this is what we do.
This is just open for discussion. So now we decided 35 centimeters of water, PEEP 18. We have a PO2 ratio anyway around 150. What do we do now? Prone position. Do we use nitric oxide, HFO? I think that most of you will not do that. Or you start some low flow or high flow ECMO in these patients. Please start voting. Luciano, what do you do first?
I think in case like this, my opinion, prone position is mandatory. It's not an option. For what we know now, I think must be applied.
You see what people answer? And this is, well, yeah. So prone position wins as a first choice versus ECMO in this condition. I remember there was a discussion in a recent meeting. We were there. You remember some question with Thomas Bain about the role of prone position and ECMO. And I think this is a good answer. What we are doing, in fact, you see,
we use a prone position also during ECMO.
Yes, ECMO, yes, no, but as a first choice now. So prone position. This is a recent study, a meta-analysis showing that even during protective mechanical ventilation, the effects of prone position are positive. The importance is to keep prone position for at least 10 hours, so a longer period of time as compared to some time ago. However, we have to remind, this is a very recent meta-analysis also on prone position, that there are some adverse events that can occur. Endotracheal tube displacement, pressure source, loss of venous access. So this maneuver is extremely important to save lives, but has to be performed with careful monitoring and people trained to do this maneuver. So it's something relatively easy, but to be performed carefully.
So don't do it for the first time on Friday night alone. Don't do it. Okay.
Okay, so in fact, we prone the patient and the plateau pressure went up a little bit at 37, but this is not an issue right now because we know that the chest wall compliance is decreased in prone position, and we have, of course, also the esophageal pressure here, and the patient improved dramatically in this case, and I can tell you that this maintained the oxygenation, and the case went well. This is just the last rule. This was not applied in this patient because we proned the patients, then it progressively improved. And it's just to mention the role of ECMO. You know this study that showed that ECMO may be very beneficial in very severe ARDS patients. In my opinion, when patients have 80 millimeters of mercury with PEEP 15 after prone position, we have no other chance to do, but most importantly, I think this technique should be reserved in trained centers and not to widespread the technique without any clear national organization for this support. And this is just to remind that. So the patient went well, and the 12 days after, it was in assisted ventilation with 15 of pressure support and PEEP 8 with higher PO252. The chest X-ray improved, and 19 days after, he was passed the spontaneous breathing trial, and he was discharged from the ICU, and then he was also came back. So let's make things simple. I hope that we were perfect in time. We have 5 minutes before eventually question or further discussion, and I try to give you a sort of overview of the main issues to be considered when we are treating such severe patients.